السلام عليكم طلبتنا الأعزاء طلبة المرحلة الخامسة. معكم أستاذ مساعد دكتور أحمد محي. إن شاء الله اليوم راح نبدي بالمحاضرة الثانية من محاضرات nasal diseases. Objectives of this lecture is to describe three important ENT diseases. These are the septal deviation, nasal foreign bodies, and epistaxis. We start with septal deviation and start with the etiology of septal deviation. Actually, the most common cause of septal deviation which requires surgery is a trauma. Other factors may play a role in deviation of the nasal septum, may include genetic factors, the position of the fetus in utero, compression of the nose during birth. Actually, during normal vaginal delivery, there will be compression of the head, including the nose, which may cause septal deviation. So that the septal deviation, which we in normal vaginal delivery, will be more likely to occur than in a baby babies who were delivered by a cesarean section. Also, septal deviation may be associated with high arched palate. Pathologically, the septal deviation is classified into three types, either sparse deviation or dislocation. Sparse means that there is a very sharp angulation of the septum, which occur as in septal fracture. Deviation, which is not sharp deviation, but it is a smooth deviation, which may be C-shape or S-shape deviation. Dislocation, this means that the lower border of the septum were dislocated from its midline position and projects laterally into one of the nostrils. This figure shows the septal deviation, which is associated with the high arch palate. We see that as the palate is high, so there is no space for the septum to be straight, which push it into septal deviation. These figures shows the pathological types of septal deviation. The first figure shows the caudal dislocation. We see that the septum is dislocated from its midline position, which is in the maxillary crest, and project laterally. The second figure shows the smooth C-shaped deviation. Third figure shows the smooth S-shaped deviation. And figure 4 showing the very sharp angulation of the septum, which is called a spur, which occur in septal fracture. This picture showing the caudal septal dislocation. We see that the caudal border of the septum project into the right nostril, and this can be seen by examination step, which is called elevation of the nasal tip. We see the caudal septal dislocation. Clinically, the nasal septal deviation associated with mainly nasal obstruction, which is the presenting symptom. Epistaxis occur in patient with septal deviation due to the changes in the direction of the air current, and this change in the direction of the air current will cause dry mucosa, and the dry mucosa will lead to formation of a dry secretion, which is called crust. And this crust, when separated from the mucosa, will lead to a wound, and this is lead to epistaxis. Other feature may be the pressure headache, which is due to the contact of the deviated septum with the lateral nasal wall, and this is called the anterior ethmoidal nerve syndrome. The other feature is the anosmia, which is the loss of olfaction. As we know, the olfaction occur when the odorant molecule reaching the olfactory area, which is situated in a narrow area in the roof of the nose. So when there will be obstruction, the odorant molecule do not reach the olfactory mucosa, and so there will be no sensation of smell. And this type of anosmia is a treatable type, because when we remove the obstruction and treat the obstruction, then the olfaction will return. This picture actually is a CT scan coronal view showing the C-shaped deviation of the nasal septum, and also we see that there is the middle turbinate in the other in the concave side is a large and containing air which is blackish in color, and this is called the concha ballosa. The treatment of septal deviation. If the septal deviation is simple and causing no problem and no symptoms, then no treatment is required. When it is symptomatic or it causing complications such as sinusitis, then surgery is required. And the types of surgeries which is done, either submucosal resection, which means the removal of deviated septal cartilage and bone, or septoplasty, which is a freeing of the septal cartilage and bone and repositioning into the midline without removal of the cartilage or bone. Actually, in most of the cases, the surgery which is done is a mix between septoplasty and submucous resection. Now we finish the septal deviation and come to the other important diseases and common in children, which is the foreign bodies in the nose. The foreign bodies in the nose may be introduced by many routes, but the most important and most common route is by a child putting some foreign body through the anterior nares and to the nose. Other routes there may be through the posterior nares, such as in coughing or vomiting, or penetrating wound, and in nasal surgery, such as the swab left in the nasal cavity. Also, when there is septal palatal perforation, as in syphilis or malignant tumor of the hard palate, the food particles may pass from the oral cavity to the nose. Sequestration of bone in situ, as in syphilis, there will be part of the bone will be sequestrated and acting as a foreign body. Also, a special type of foreign body, which is calcification in situ of inspissated mucopus of foreign body, which cause a rhinolith, which will be discussed separately. The most common site of foreign body in the nose is usually beyond the constriction at the nasal vestibule. The nasal valve area is situated between the nasal vestibule and the nasal cavity. Just beyond this nasal valve will be the foreign body present. Pathologically, the foreign bodies is divided, and foreign bodies are divided into three main types: either inorganic foreign bodies or organic foreign bodies, and a special type of foreign bodies which is the bottom battery. The inorganic foreign bodies are usually inert, such as the plastic material, and may remain in the nose for years without causing any inflammation. The other type is the organic foreign bodies, which cause early inflammation and infection of the mucous membrane, and this would cause granulation, tissue formation, ulceration of the mucosa, and epistaxis. Bottom batteries is a special type of foreign bodies. These will leak alkaline material, and this will cause severe inflammation and necrosis of the bone and cartilage, and so they should be removed as emergency case. Clinical features of nasal foreign bodies. The most important thing is the presence of history of putting foreign bodies into the nasal cavity, usually by a child. So it is more common in children under 4 years of age, but actually not a child or a baby under 1 year or under 6 months, but older, like those in 3 years or 2 years and 4 years. The most important presentation is unilateral foul-smelling nasal discharge, which is purulent discharge, and it is characteristic. And any child presented with unilateral foul-smelling nasal discharge should be considered to have foreign body until proved otherwise. Bleeding may occur as a result of infection and granulation tissue formation, also nasal obstruction. By examination, by elevation of nasal tip, or even by anterior rhinoscopy, or by endoscopic examination, we can see the foreign body inside the nasal cavity. Diagnosis by X-ray. Also, X-ray is useful when the foreign bodies are radio opaque. The only treatment of foreign bodies is the removal. and the removal is done through the anterior nares under local or general anesthesia according to the cooperation of the child, either removed by hooks or by a probe passing beyond the foreign body and then drawn forward. This is especially done in rounded nasal foreign bodies. In rounded nasal foreign bodies, we cannot remove it by forceps because the forceps will push the foreign body more posteriorly. So that we use a probe or a hook and pass it just above the foreign body and then behind it, and then draw the foreign body forward. Also, a sucker or forceps may be used to remove the foreign bodies which can be crushed by a forceps. The foreign bodies which we talk about, these are inanimate foreign bodies. Another type which is rarely seen of nasal foreign bodies is the animate foreign bodies such as the maggot or the ascaris. Concretion of calcium, magnesium, phosphate and carbonate around a foreign body or a speciated mucopus or a blood. Clinically, the patient presented with unilateral nasal obstruction, and on examination we see a brown or grayish large irregular mass near the floor of the nose, which is by palpation by a probe it is stony hard. By x-ray it will be radio opaque. Treatment, it should be removed under general anesthesia because it is adhesive to the adjacent tissue, and removal will be accompanied by bleeding, and sometimes it is very large and need to be broken by a forceps in the nasal cavity and then removed piecemeal. These are figures showing the rhinolith as seen by CT scan, and also the figure 1 showing the rhinolith itself. Now we come to the third topic, which is the epistaxis, which is a very important and common emergency disease in otolaryngology. Epistaxis, it is defined as bleeding from the nasal cavity. Etiology of epistaxis, we define as first we have the etiological factors. The etiological factors may include the most common cause of epistaxis is unknown. So 80% of epistaxis is idiopathic. Other important causes include trauma, coagulopathy, such as idiopathic thrombocytopenic purpura, drugs such as using aspirin or warfarin, chronic granulomatous disease such as sarcoidosis, inflammatory diseases such as rhinosinusitis, neoplastic diseases such as angiofibroma, which is a vascular tumor of the nasopharynx, hereditary conditions such as hereditary hemorrhagic telangiectasia, hemophilia, Van Willebrand diseases, iatrogenic such as nasal surgery or use of topical nasal steroid. In nasal surgery, actually we induce when during for example septoplasty, there will be some bleeding, and this is considered as part of epistaxis. The second thing is the etiological association, means that it is associated with epistaxis more likely than the actual cause of epistaxis. These etiological association include septal abnormalities such as septal spare and perforation, alcohol consumption, and hypertension, which is considered now as not a cause of epistaxis, but it is associated with severe epistaxis. The site of epistaxis, the most common site of epistaxis is called the Little's area, which is situated in the anterior-inferior part of the nasal septum and contains what is called the Kieselbach plexus, which is formed by the anastomosis of anterior ethmoidal artery, greater palatine artery, sphenopalatine artery, superior labial branch of facial artery. Epistaxis is divided into two types, either active epistaxis or recurrent epistaxis. The active epistaxis means that the patient presents and he has active bleeding at the time of examination. Recurrent epistaxis means that the patient, when present for examination, there is no epistaxis, but there is history of recurrent attacks of epistaxis. This figure shows the little area which is situated in the anterior inferior part of the nasal septum and containing the Kiesel-Bach plexus, which is the most common site of epistaxis. Now we come to the management of active epistaxis. For the management of active epistaxis, we need first, and the most important point is first to stop the bleeding. We have many measures to stop the bleeding. First, pressure on the nostrils. The patient sits on a chair and leaning forward, and simple pressure on the nose by fingers below the nasal bones for 10 minutes with ice packs may be applied to the nasal bridge to induce vasoconstriction and decrease bleeding. Second is the cottonoid wool soaked in xylometazoline, which is called the atropine, which is inserted gently into the anterior nasal cavity, and also by pressure by fingers on the nostrils repeated. Cauterization. If the previous methods fail to stop epistaxis, then we have to do cautery. This cauterization is done if we can see the bleeding point. If we cannot see the bleeding point, we cannot do cauterization. But if we see the bleeding point, the best treatment is to cauterize the bleeding area. Cauterization is divided into either chemical cautery by using silver nitrate or trichloroacetic acid, which is more effective than silver nitrate, and the chemical material is applied by using very smooth cotton wood carrier around the bleeding point, not on the bleeding point itself, because it will cause rupture of blood vessel and more bleeding. So we cauterize around the bleeding point. The electrical cautery, actually it is more effective than chemical cautery, but it is more painful, and in young children it should be done under general anesthesia. It is done by using a small instrument which is called galvanic cautery, which cauterizes the bleeding point by electrical current, leading to coagulation of blood vessels and stop the bleeding. We have a very important note that we have to avoid cautery on the both sides of the nasal septum, in both opposite sides of the nasal septum. And when you do cautery on one side of the nasal septum, we have to wait. If we want to do cauterization of the other side of the nasal septum opposite to the first side which has been cauterized, we have to wait for 4 weeks. This is because we have to avoid the necrosis of the septal cartilage and formation of the septal perforation. Nasal packing. Actually, anterior nasal packing is used when we cannot see the bleeding point, and the bleeding didn't respond to the previous method to stop the bleeding, and we cannot see the bleeding point, or even with cautery we cannot stop the bleeding point. Then we have to do the anterior nasal packing. So it is used when we cannot see the bleeding point. It is done by using ribon gauze soaked with bismuth, iodoform, paraffin paste. The bismuth is detergent, iodoform is antiseptic, paraffin is lubricant for easy insertion. The pack is inserted by using teleforceps and inserted layer by layer, starting from the nasal floor to the roof, to produce good pressure inside the nasal cavity to stop the bleeding. The pack can be removed after 48 hours, and the pack should be done on both sides of nasal cavities, even if the bleeding is from one side. This is because we have to do there is a cross circulation of blood across the midline from the nose, and we have to do good pressure from both sides of the nasal. This figure the first figure showing the anterior nasal packing, and the second figure shows the plunging which occur after chemical cautery. Posterior nasal pack. Actually, if the posterior nasal pack is used when all the previous methods to stop the bleeding didn't succeed to stop the bleeding, so we have to use posterior nasal pack. It is used when the bleeding point is posterior and the bleeding doesn't stop by anterior nasal packing. Then we have to use the posterior nasal pack, which are placed in the nasopharynx under general anesthesia, and always it is accompanied by anterior nasal pack. يعني بتسوي posterior nasal pack لازم تخلي بعدين وراها anterior nasal packing. Foley's catheter may be used instead of posterior nasal pack, and the catheter is passed through the nostrils and to the nasopharynx, and then the balloon is expanded with 7 ml of normal saline or air to cause pressure on the posterior part of nasal cavity, and then we also do anterior nasal packing. this shows the procedure of doing the posterior nasal packing by under general anesthesia, and also the posterior nasal packing, or the alternative to posterior nasal packing, by using Foley's catheter. Finally, if the bleeding doesn't stop in all previous methods and it is severe, so we have to do operation which may include arterial ligation or embolization. As we mentioned, the first thing in the management of epistaxis and the important thing to do is to stop the bleeding. Then we have with the method of stopping the bleeding, we have to do the supportive measures if the patient needs, which include first, hospitalization of the patient is done only in severe cases. Second, resuscitation of the patient by IV fluid and blood transfusion if needs. And we have to do blood group, blood cross match, and repeated hemoglobin estimation. Antibiotic cover when the pack is put for more than 48 hours, or the pack is only ribongos without PIB. Analgesia to relieve pain, because as we know the pain will increase the blood pressure, and increased blood pressure will cause more bleeding, so we use the analgesia. And as we said, hospitalization is done only in severe cases. The last thing in the management of epistaxis, active epistaxis, is the treatment of the underlying cause, which means that by history, by good history, and by examination and by investigation, we reach the cause and treat the cause accordingly. So if the patient has sinusitis, we have to use antibiotic. If the patient has tumor or polyp, we have to do surgery for resection and removal of the tumor. And this is done, of course, by taking full history examination and investigation. So the three methods, which are the three steps in the management of active epistaxis, is first to stop the bleeding, and with it resuscitation of the patient, and finally find the cause and treatment of the cause. Now we come to the recurrent epistaxis. As we said that in recurrent epistaxis, the patient presented with history of repeated attacks of bleeding from the nasal cavity, but there is no active bleeding when the patient examined by the examiner. Only we see the bleeding point. The best treatment is by cauterization on each side of the bleeding point, and we repeat, we do not cauterize the bleeding point itself to avoid rupture of the blood vessels, and which cause more bleeding. We should avoid cauterization, as we said, of both sides of nasal septum at the same time to avoid septal perforation. So if we do cautery of one side of the nasal septum, cauterization of the other side, if needed, on the opposite side of the first side which has been cauterized, should be done after 4 weeks to avoid septal perforation. Finally, the general advices to the patient to avoid recurrent epistaxis include: first, avoid nose picking. Second, avoid hotness. يعني انه مثلا خصوصا في الصيف انه ما يطلع الشخص بالشمس فترات طويله، انه مثلا اذا مريه مثلا تخبز، نحاول انه نقولها ما تخبز، لانه لا نريد دائما يكون وجهها يم التنور وتتعرض الى حراره شديده ويؤدي الى dryness of the nasal secretion ويسوي لنا crustation، وهاي الكراست when separated will cause epistaxis. And antibiotic ointment applied to the nasal vestibule and the little's area twice daily. This is very important to keep the nasal mucosa moist and not dry.